Thank you very much for the lovely introduction. Let me pull up my slides. Go. Oops. All right. Can you all see the slides?
Yes, we can.
I feel it's always a standard question these days. Minimize the whole bar here. Okay. It's a pleasure to be here. Thank you so much for inviting me to give a social psychology perspective on the pandemic and thinking about future pandemics, and really sort of one of the big factors, and what's also my area of research, is to think about the communication aspect, in particular thinking about how we can communicate scientific empirical evidence to people in a way that's understandable, that they can then work with. And also then the question of, well, what effects does the communication of these kinds of empirical scientific evidence, the uncertainty that goes with it, what effects does that have? And I'm hoping I can provide some little snippets and some little interesting insights from the research that I've been doing over the last 4 years or so here in Cambridge. So I want to start us off by thinking about different communication aims. I've just mentioned, how can we communicate uncertainty, for instance, and you might rightfully ask, well, why do we need to communicate uncertainty? And it's true that if you as a communicator fall on the persuade arm of things, thinking about marketing, for instance, they might not. So for instance, if I want to sell you a chocolate bar, I will not tell you that it's really bad for your health. I will just highlight how yummy it is and how much happier you'll feel afterwards. On the other end of the spectrum, we're talking about informing people. So here it's really about getting them to understand a piece of information, feel better informed, and be able to make decisions. Cases are, for instance, giving informed consent. There, it's really essential what we're giving evidence in court. The research that I've been doing at the Winton Center is centered on the informed side of the spectrum. So really thinking about, well, if we try to communicate something, how can we do it in a way that people understand it and can use it? And what effects does that kind of communication have? Here's just an example of the kind of informative communication, how that would look like. This is an infographic that the team at the Winton Center put together at the time when the link between the blood clots and the AstraZeneca vaccine was discovered. And this was also used in one of the press briefings in the UK. And what it tries to do is really highlight and sort of allow people to weigh up what are the benefits from getting a vaccine and what are the harms. And that is complex. It depends on, for instance, the exposure risk, if there's little or a lot of virus around. We also know now that it's different for different age groups, and really trying to visualize it in a way that people can absorb the information and can see the kind of differences that are going on here. So let me come to the main questions of what I'm going to talk about in the next 10, 12 minutes. And that's the question of how to communicate empirical evidence and the uncertainty around it. And importantly, what effects does that have? There's going to be two parts in the talk. First part, I named numbers, not just a number. The format matters, context, and also some psychological variables such as social influences and our experience, our emotions. The second part, communicating about the known unknowns, uncertainty. There's what we call direct uncertainty. So rarely an estimate is really precise. There's always some uncertainty around it. Indirect uncertainty, what kind of evidence is that based on? So what's the quality of the underlying evidence, and thinking more broadly around transparent and open communication. So let's start with looking at format. This is a study where we asked people, how would you rate the risk if you were told your chance of dying of COVID-19 if you caught it was? And then they were shown in a randomized order these different risk levels from 0.1%, fairly small, to 20%. And they were given a slider to indicate their personal subjective risk rating from 0 to 100. And what we see is that people, as we might expect, rate a 20% risk as more risky than a 0.1% risk. Now, another group of people received the same risk levels, but in a frequency format, not a percentage format. And what we see here strikingly is that throughout the bank, the subjective risk level is higher when people are presented with frequencies compared to percentages. And this picture gets even more striking when we look at this 1 in X format where the denominator is changed. And that, for several reasons, is a really bad format to go with, because it's very hard to compare the numbers. But even just thinking about the frequencies versus percentages, formats that are often used, really to understand that these can have different effects on people's perceptions and how they will then deal with the risks or the information. Now, thinking about context, and this is a study in which we try to see whether we can use context to help translate numbers for people into their own subjective risks. So for instance, if I tell you, is a 10% risk big or small, you might say rightfully, well, of what? Getting a headache, dying for a 90-year-old, for a 10-year-old, and so on. So in this study here, we ran a series of qualitative interviews and quantitative surveys where we tried to see how can we communicate personalized risk to people. And what came out as the best approach within our research here was the so-called risk ladder, where we showed the different percentages. It doesn't go to 100%, it's cut at 30 because rarely the risks were higher. And it shows these illustrative personas. So for instance, a 0.1% risk is for a 40-year-old with no health conditions, while 27% is for someone with all these kind of health conditions, diabetes, kidney disease, and so on. And that allowed people to understand it more. Interestingly, giving people comparators such as how COVID compares with the common flu was considered less helpful to people. Now, in this piece of research, we looked at risk perceptions of COVID-19 in 10 different countries around the world. This was early on in the pandemic. And we wanted to see what predicts risk perception, what are influential factors. And we had a range of different predictors. And some important ones I want to highlight was, for one, direct experience with the virus. So have they had the sort of really visceral engagement with it, that they or a loved one fall ill? What about the kind of objective societal knowledge that we have? What do scientists know about the virus? But also things like the information that we receive from family and friends or from social sources. This is a plot here where we show the different predictors ordered by their relative importance, and only the red ones are statistically significant. And what's important to take away here is that among the top 3 predictors was direct experience. So the more experiential, emotional factors here played really a huge role across these different countries in predicting risk perception. Also quite high up was what's called the social amplification, so getting information from family and friends, talking to the social circles. And interestingly, the sort of objective social knowledge, what do scientists know, was not even predictive. So this highlights the role that some of these more psychological factors can play in terms of people's risk perception, how they deal with that. This is another example of social influence. Here we ran a study where we looked at people's hoax beliefs. Is coronavirus and COVID a hoax? This was done in the US with a US sample. And we ran 2 samples, one before President Trump at the time was diagnosed with COVID, the other one afterwards. And what we saw is that particularly amongst conservatives, so those who might align with Trump's ideology and beliefs, that there was a significant reduction in hoax beliefs after he was diagnosed. So kind of seeing how sort of social media and these influential figures can really play a role. Now, moving on to the second part, talking a bit about uncertainty. I want to start us off with the concept of direct uncertainty. So this idea that a number that we, through the scientific process, come up with is not precise. There's a confidence interval around it. So we ran a study here in 10 different countries with an international sample, and people were randomly assigned to one of the 3 conditions, either a control condition where they just received some information around COVID-19 and hospitalization rates. In the numeric uncertainty condition, they received the same information, but they were not just given the 17% figure, but it said here in red, it ranges between 10 and 34%. So highlighting that uncertainty around it. And in the verbal uncertainty condition, there was no number, but it said, well, it could be higher or it could be lower. And we looked at outcome measures such as their perceived uncertainty of the information, perceived trust of the number, and importantly, the trust in the source, in the communicator of the information. What we see here, this is a small print, but the important point here is that there are not that many significant stars, meaning that in all these different countries, there was very little difference in terms of perceived uncertainty, and importantly, if you look at the bottom line, this source trustworthiness, so how the communicators are perceived. Meaning that while there are small differences that possibly communicating this uncertainty make, it doesn't hugely undermine trust. So it seems to, especially with often the numeric information, doesn't seem to have a negative effect. And we ran some other studies in a different context following up on this and found similar results. Now, but what about this indirect uncertainty, thinking about the quality of the evidence? We ran a series of studies here. I'm going to present one in more detail. That's from the paper on the left here, where we presented people with this infographic. We took that from one that was published by The Lancet during the pandemic, and then we amended it for our experiment. And this one here shows the effectiveness of eye protection to reduce the chance of infection and transmission of COVID-19. It shows in blue, well, what is the chance with eye protection? 5.5%. Without eye protection, 16%. And below, it gives an indicator of the quality of the evidence that information is based on, in this case here, high. And what we did in one of our studies is that we assigned people randomly to see the effectiveness information, but then receive a high quality of evidence indicator, another group a low quality of evidence indicator, and a third group received no disclosure of the quality of the evidence. And what we saw is that people took this quality of evidence information into account such that people perceived the information as less trustworthy and eye protection as less effective when they received this cue that the information was based on low quality evidence compared to high. Now, interestingly and importantly, this is what we saw for the non-disclosure group. There was no significant difference between their perceived effectiveness and trust between the non-disclosure and the high quality of evidence group. What does that suggest? Well, possibly that if people are not given any indicator as to the quality level, they might assume it's based on high quality evidence. That, of course, leads to a range of ethical considerations around the disclosure, especially when the quality of the evidence is low. Now, for the last part here, I want to move us on to take a bit of a broader view. So not just thinking about uncertainty, but really more generally open, transparent information where we really openly try to tell people this is to inform you, offering balance, try to prevent misinformation, misperceptions, and so on. And this was sort of formalized in these 5 rules for evidence communication, which the board of the Winton Center where I work put together and put out in this Nature commentary. And then our team and also the Cabinet Office rightfully was interested to ask, well, what happens if we put these 5 rules to an empirical test? Because if we're so open about all the uncertainties, tell people all the things that we don't know, can this erode public trust? What happens if we follow this communication approach? So what we did in 2 different studies is that we took current government communications at the time, one around COVID-19 vaccines from the NHS website, and one around the question of building a new nuclear power plant for energy production in the UK. And we fed these through the 5 rules for evidence communication to come out with a more balanced communication. Sort of what this looked like in concretely for the persuasive one, this little snippet here started by taking this information from the NHS website at the time, saying the vaccine is safe and effective, and so on. For the balance one, this was amended to say things like all medical treatments have potential benefits and potential side effects, and so on. This was about half to a page of text that people read. Then we ran these 2 studies, one on the vaccines, the other one on nuclear power, and we were interested in if we follow this balanced versus a more persuasive approach, how does it affect trust? And importantly, given that these topics can be really quite polarized in the population, what role does that play? Some people are very anti-nuclear power and very anti-vaccines, others are very pro-nuclear power and pro-vaccines. Do we see a difference for those different groups in the population? And here's what we found. We saw that for those who held quite positive prior beliefs, there was actually not a difference with regards to their perceived trustworthiness of the information when they received the balanced account or the more persuasive account. However, for those who held negative views on vaccines and on nuclear power, we saw the following. They showed that they were more trusting of the information, more receptive when they were presented with the balanced account compared to the persuasive one. We saw the same results for the trustworthiness of the communicator of the source. And importantly, we also looked at psychological reactance, which is this measure where people read something and they're very dismissive of the information and they disengage. And we found that when people with these negative prior views were shown the balanced account, they were less dismissive. They showed less psychological reactance, which is really important when we think about communicating to those kind of populations and people. So with that, I'm at the end of this little whirlwind tour. I'd like to give a shout out to my amazing team and colleagues that I'm working with at the Winton Center, and I'm very happy to discuss any of those bits further in the discussion. Thank you very much.